Добрый день, уважаемые коллеги.
Good afternoon, dear colleagues. I'm very happy to welcome all of you at our session AI in Healthcare, which traditionally is conducted for the third year running, despite the pandemic and a lot. And also owed to the pandemic, the last year has been very fruitful for technological development, which proved its efficiency and allowed us to combat the COVID pandemic. Today, we are going to hear 6 presentations from our distinguished colleagues. It is important to note that you will see a QR code on your screen. We'd like you to scan it with your mobile phone. Using this, you will be able to access the chat and the question forms for the Q&A. Please write us the questions, and at the end of every presentation, we will ask the most frequent questions, and the speakers will endeavor to answer. We will begin with Dmitry Oleg, who is also fighting the COVID pandemic. Dmitry and Oleg, you have the floor. Good afternoon. My name is Dmitry Umerenkov, and I will be able to tell you about a joint project between Sberbank and the Krasnoyarsk local hospital on forecasting pneumonic and other COVID complications based on case histories. This project had grown from text data analysis. It had actually begun with a pneumonia research pre-pandemic. However, with COVID pandemic, it had become more important. The key problems we are trying to tackle here is prioritization of patient routing during mass admissions, because in these cases, the doctors insufficiently qualified to assess the severity of cases for patient routing and filtering, leaving them in the admissions room or taking them straight to the ER. We had developed a system which is based on modern text processing algorithms using AI and neural networks. The first model we had done and presented our colleagues was the model trained on other data from other regions. We used the model to predict the rate of ICU hospitalization and admissions. We attempted to also trial the model using a patient panel from Krasnoyarsk Regional Hospital. According to the results of these trials, we decided to add X-ray and laboratory test data to the analysis, since these forms also contain important data, and they can also be used in the data processing models. So we don't take the actual models, but the textual descriptions. And since the data had become much longer, it stopped fitting into the classic BERT length, and we are using long format model, which allows us to process multi-length documents, various length, which greatly facilitates our work. Another problem we had faced is a problem related to test imprecision. Many patients showed negative tests for COVID at admissions. However, their final diagnosis had COVID. And we considered whether it's worth training models for COVID separately, whether it should be based only on test results, but also the results of doctors' diagnostics. However, we decided to use the model which will use all the patients, analyze all the patients without the breakup into conditions and illnesses. Now, regarding the timeline, our project began May last year. By September, we received new data, and by January, we saw a situation where a system started predicting. My colleague Oleg Cherkashin from Krasnoyarsk Regional Hospital can tell us more.
Да, начали заниматься делом до пандемии и
We had begun our work pre-pandemic, and the time was ripe. In May, when we launched the model, we learned that it did not provide the desired outcomes. It had taken quite a long time to develop the model that was viable. Certainly, results were results. There were results, and the next step was analyzing this. Based on the analysis of January admissions, over 1,100 patients in total, 260 patients were used by one model. We used various models for COVID patients and other patients, and 280 in the next panel. Also, we realized throughout the analysis that the audience are the patients going to ICU. These are serious patients, and the degree of severity doesn't need to be predicted. The next category here are the patients transferred from clean zone after serious surgery, and they were also serious patients, so that was clear. So we focused on the patients which were admitted into pulmonology departments and then became worse. Out of 1,000 patients, 20 of these were admitted to normal lungs department. 6 of these later died after ICU treatment. If we look at the AI modeling, the COVID model highlighted 100 people. 75% ended up in ICU, 18% diseased, which is significantly higher than other patients. The pneumonia, the lung model precision was lower. For this reason, we had taken a decision to use only one model of COVID patients. These are the results. We accordingly removed one of the models and left the new model in place. Doctors noted high risk levels for certain patients. However, how high was the severity, whether they will go to ICU, was certainly uncertain, 50-50. And we wanted to introduce a series of grade rating, to see if we were better able to predict the outcomes. And out of the 100% lethal outcome category, the doctors confirmed our benchmarking. When we began working in detail, it turned out that patients often have heavy accompanying pathologies, adjacent pathologies like cancer in the later stages or heart conditions, heart pathologies. Then we decided that we need to additionally assess the degree of severity of pneumonia of the lungs, and the AI system used a score system for the rating severity. This is how we developed the level of severity on pneumonia. However, this was not enough, because we needed to understand the dynamics, and this is why seriousness was assessed at the point of admissions, and also today, when we analyzed to date, when we analyzed the whole list of patients. Then the next step was involving the doctors, so that they're aware of the system processing and react. So we engaged the doctors and asked them about how they plan to correct their treatment tactics according to this screening. Quite daily, we run a meeting with Vadim, with the chief pulmonologist for Siberia, for the Krasnoyarsk region, who personally supports all the serious patients in our hospital, and also the severe patients identified by AI. So there is a treatment tactic developed, corrected, which certainly impacts the further patient history. This is the interface. At the bottom, you may note how these reports are processed and marked. Analyzing our results, at the bottom, you see the share of the total number of patients during the COVID pandemic waves. 10% was selected by the system as the target group, as the panel. Now, at the top in the rows, we see the frequency of ICU admissions, and these are the patients that end up in ICU in 40% of cases, after being admitted stable. 30% of those admitted into ICU later show mortality. These numbers certainly were high, which was quite concerning. We decided to look into it in detail. We had taken the statistics across all hospitals, since the hospitals are pretty similar in terms of capacity. We analyzed the degree of mortality across the hospitals, and we see that the growth in mortality was observed across the board. The difference was change to the strain, change to the virus. Virus is becoming more lethal and infectious. And if we look at the comparison of mortality across the hospitals, you'll see May is the point when we first launched the system, and we actually showed less growth on mortality than other hospitals. So we brought and we also see that orange is the AI identified indicator. We can see that this level is also dropping. If we also look at the risk levels we had selected from super high to low, low are those not identified by the system, we will see that all of the groups except for low risk, color-coded green, are falling. And for this reason, it cannot be stated that only AI has achieved that, but also we'd like to believe that part of this life saved are owed to AI. Thank you. Thank you, dear colleagues, for your presentation. Do you have any questions? Let me ask a question. I'd like to find out the practical application. Certainly, it is fascinating in terms of research, but are the doctors using this system? Is it implemented? Do we have any feedback from the doctors that it helps? And also, or is it just another gimmick that was put there to look good? Well, first of all, as I mentioned earlier, the system has been closely integrated into our systems and our treatment protocols for the last 12 months. And certainly a third of all the patients of our city go through our hospital. So we have very high patient admission rates. The doctors react very differently. The feedback is different in terms of some of them reacting with mistrust, while others instead say that this allows me highlights the points I could have missed. As I initially mentioned, it is very useful at the crossroads of a problem when the patient begins being treated by ophthalmologists or trainees, university interns. In this case, certainly it helps and it highlights the problems, it increases the accuracy of treatment. Thank you.